Welcome, everyone, and thank you for joining us at this special lecture on psychiatric diseases. My name is Suzanne LeBlanc, the Director of Clinical Relationships at the Focused Ultrasound Foundation. As you know, psychiatric disorders have received much attention, especially given the rise in mental illnesses during the COVID pandemic. The Focused Ultrasound Foundation has supported research and clinical trials to investigate the potential of focused ultrasound to treat various psychiatric illnesses, such as obsessive-compulsive disorder, depression, addiction, and others. Focused ultrasound has the potential to play an important role in the treatment of these patients, many of whom experience severe side effects from traditional medical therapy, are treatment-resistant, or want to avoid invasive surgical procedures. It is now my privilege to introduce Dr. Eitan, who will be delivering this special lecture entitled Focused Ultrasound for Psychiatric Disorders. Dr. Eitan graduated from Hadassah Hebrew University Medical School in 2001 and is the founding director of research and the Neuropsychiatry unit at Jerusalem Mental Health Center, affiliated with Hebrew University Hadassah Medical Center. She received training in the theoretical background, methods of research design and data analysis in the biological psychiatry laboratory at Hadassah Hebrew University Medical Center. Using this knowledge, she pioneered a new clinical and scientific field in Israel, deep brain stimulation treatment for psychiatric illnesses. Dr. Eitan served as the main psychiatrist in a multi-center European clinical study which investigated the impact of DBS treatment in depression and treated the first obsessive-compulsive disorder patient in Israel with deep brain stimulation. In 2016, she worked in the functional neuropsychiatry lab within the Department of Psychiatry at Brigham and Women's Hospital, Harvard Medical School. While there, she joined our Focused Ultrasound Psychiatric Disease Steering Committee, where she quickly took the lead on designing a unique clinical trial to study MR-guided focused ultrasound capsulotomy for patients with obsessive-compulsive disorder. I am sure you will find this session informative and engaging. Enjoy.
Hello, I'm Renana Eitan, and we're in the 7th International Symposium of the Focused Ultrasound, and we'll speak now about focused ultrasound for psychiatric disorders. Why do we actually need focused ultrasound methods for psychiatric disorders? So we know that mental disorders are common and debilitating, and they are a major cause of disability and suffering. Here you can see the daily, this is a disability adjusted life years score. This is at the United States, 2017, for patients aged 15 to 49. And you can see that many psychiatric disorders are very high in disability rate. You can see depression here, anxiety, schizophrenia, eating disorders, and here you can see the drug abuse and alcohol abuse and self-harm. If we add all the psychiatric diseases, we can get into more than 25% of the disability life years is caused by psychiatric disorders. But you can also see here that it's not only the rate of the disability that is caused by psychiatric disorders, but also the rate of, or the annual change during the past 25 years. And you can see that while many disorders are getting less disturbing for the patients, the psychiatric disorders are actually getting more and more prominent in the past 25 years. So the mental illness burden is increasing over the past 25 years. So we know how to treat our patients. We have psychotherapy, we have medication, we can hospitalize the patient, we use support group or self-help, and we also have brain stimulation. But up to 1/3 of the psychiatric patients don't reach the remission despite this optimal care. And these patients remain significantly disabled, and therefore they are classified as treatment-resistant mental illness. So we need new treatment options for psychiatric disorders. And this is why we use the focused ultrasound for these disorders. The new treatments should be effective and safe and available to a large population. What do we know about the brain function in psychiatric disorders? We know that mental processing is based on brain circuits. It's not that we have a specific pathological brain area that causes a psychiatric illness. It is more related to a network, to a circuit, which is a communication between different areas of the brain. So mental brain circuits combine usually both cortical and subcortical areas. And we can identify specific networks that are related to specific symptoms or specific psychiatric diseases. When we look for focal areas for neuromodulations in the brain, we look at the brain as a big network. So information from the cortex actually passes through the cortical striatal pathways and converges into small nexus, which is the basal ganglia, which is actually gray matter within the white matter of the brain. And after a sophisticated processing, the information from the basal ganglia returns to the cortex. The projection systems allow for convergence and integration of both motor, cognitive, and limbic information at the level of the basal ganglia. So targets for neuromodulation could be the cortex, the cortical striatal pathways, or the basal ganglia. And it's important to emphasize that neuromodulation targets in psychiatry should be specific for the limbic or the cognitive networks. We can divide the neuromodulation in psychiatry into cortical and subcortical neuromodulation. We have many methods for cortical neuromodulation, and these are based on electrical and magnetic modulation. For example, we have the TDCS, which is an electrical modulation. This is a non-invasive neuromodulation. And we also have the transcranial magnetic stimulation, which is also non-invasive and usually stimulate the cortical areas. We also have subcortical neuromodulation. For example, we have electrical neuromodulation, which is the deep brain stimulation, where we have a thin electrode inside the brain with a pacemaker. And we also have ablative procedure, subcortical areas that we actually destroy or ablate. We can do it mechanically. We can use thermal ablation. And during the past decade, we can also use non-invasive ablation, which are the focused ultrasound ablation, where we can actually use the focused ultrasound to destroy a very specific area within the subcortical area. So the idea of the ablation is actually not new. During the past decades, neurosurgeons and psychiatrists have used many types of brain ablation. For example, anterior capsulotomy, which is ablation of the anterior limb of the internal capsule, or anterior cingulotomy, which is ablation of the cingulum, or subcaudate tactotomy, and limbic leucotomy, which is a combination of the subcaudate tractotomy and the anterior cingulotomy. One of the most pronounced ablation sites is the anterior limb of the internal capsule, which we call capsulotomy. You can see here that you can do capsulotomy using different methods. This is the thermal capsulotomy, the gamma knife capsulotomy, and also the deep brain stimulation, which is the electrical stimulation. They all in the same area of the anterior limb of the internal capsule. This is a very important area of the brain, which actually connects the prefrontal cortex and the deep structures. And we think that this is the reason that capsulotomy or DBS in this area is very effective for many psychiatric disorders, and especially for obsessive compulsive disorder. This is an example of anterior capsulotomy that was made by the MR-guided focused ultrasound. You can see the figures here. This is the baseline, and this is the figure immediately after the procedure, 1 week, 1 month, and 6 months after the procedure. So you can see that the outcome of the focused ultrasound ablation is similar to the former gamma knife or open capsulotomy. If you look at the clinical results of the anterior capsulotomy for OCD, you can see here the results of studies of open capsulotomy, gamma knife capsulotomy, or focused ultrasound capsulotomy, and you can see that the results are similar in all these methods. The most important thing to note here that it takes a long time to the clinical effect. If you want to get a significant clinical effect in all these methods, you have to wait from 6 to 12 months to actually see the effect of the capsulotomy on the clinical OCD symptoms. If you want to summarize all the clinical results that we have today about anterior capsulotomy for OCD, you can see that there are many studies. Most of them are open studies, and we don't have that many patients that went through these procedures, but we have from 2015 over 20 patients reported that had focused ultrasound capsulotomy, and you can see that it takes time for the effect of the procedure to be significant. To be clinically significant. And you can see here that most of the patients that went through this procedure were patients with severe OCD. This is the white box score. This is the Yale Brown OC score. This is a score from 0 to 40. 40 is the maximal OCD symptoms. And you can see here that all the patients had a white box score of 32 and above. And after the treatment, you can see that there is a significant change in the white box score from 33% to 55%. And many patients got into remission after the procedure. So these are all very severe OCD patients and treatment-resistant patients. If we had used another type of treatment, they would probably not benefit at all. So the numbers here are very impressive. If we take a short look at the parallel treatment, this is the deep brain stimulation of the same brain area, the anterior limb of the internal capsule. You can see here in this illustration the fibers of the anterior limb of the internal capsule, and this is the electrode that stimulate actually this area. You can see here that this is the same brain location as the site for the anterior capsulotomy. The clinical results of neuromodulation, of the DBS neuromodulation, are similar to those of the anterior capsulotomy. You can see here that there are different targets for deep brain stimulation for OCD patients. Mostly, this is the anterior limb of the internal capsule. The last study was with 30 patients, studied by the Medtronic company, European study. And you can see here again that the patients have a very severe OCD, treatment-resistant OCD, and the change of the clinical state is significant. And let's say 50 to 67% of the patients get into a remission after the DBS treatment. So the clinical effect is actually similar with the ablative procedure and the deep brain stimulation for OCD. Even if we know where we want to put the electrode or what is the specific site for ablation, it's difficult to locate the specific area within the patient's brain. So we can use, of course, neuroanatomy. We use imaging. We look at the brain slices of the MR study, and we can locate the specific area that we want to stimulate or we want to ablate. It's extremely important to realize that the putting the electrode or making the ablation in the exact location is critical for the clinical effect and to avoid adverse events. This is an example from the OCD study that I mentioned before. You can see here that patients have their active electrode. This is a DBS study, and you can see where the active electrode is. And you can see that if you locate the electrode in the right place, and these are the stars here, the Y-box improvement is better than locations that are a little bit far away from the location that we actually want to get in these treatments. So we can use the imaging, but today we can also use tractography. We can use the fibers. We look where the fibers are going, and we know that we need those fibers to actually connect with the prefrontal cortex. And this is another method that we can actually use before the surgery to make sure that we will target a specific area for ablation or for stimulation. These are studies that use the lead DBS system with DBS electrodes in the anterior limb of the internal capsule and here at the subthalamic nucleus. When we use the DBS procedure, we can also get into the right location by electrophysiology because we have an electrode within the brain. We can record the electrical activity of the deep structures of the brain, and then we can make sure that we are actually at the right place for stimulation. Here you can see an example in an OCD patient implanted into the subthalamic nucleus, into the STN. So you can see that when we record from this electrode, while we are passing through the STN, we can define two different areas. One area is area with a beta frequency oscillation, and another area is an area with a theta alpha oscillatory activity. And we know actually that the beta area is the motor area of the STN, and the theta alpha area is the limbic area of the STN. And thus we can actually make sure that our electrode is not only in the STN, but also in the limbic area of the STN. This is what we learned from many Parkinson's patients where we explore the STN. We can see that the electrode could be in an area with a trajectory with an alpha theta activity. And this is actually the limbic area of the STN. When we look at OCD patients again, we can see that this theta alpha oscillatory activity is negatively correlated with the OCD symptom. This is a patient that we recorded the STN not only during the surgery, but for a year after the surgery. And you can see the change in the Y-box score. And when we look at the recordings that we actually made for a year after the surgery, we can see here that the OCD symptom severity, the Y-box score, is actually negatively correlated with the theta alpha activity that we recorded from the subthalamic nucleus. We also used OCD provocative test. This is a special test where we show the patient's OCD provocative figures and just aversive and neutral figures. And you can see here that when we record the theta alpha activity from the STN in OCD patients, you can see that when we provoke the OCD symptoms, the theta alpha activity decreases. You can see it here. If you compare it to the negative or the aversive or the neutral figure. So if we want to sum up everything, we have many methods for neuromodulation and ablation in psychiatry. We have the ablation procedure, which is mainly today we do capsulotomy. We can use thermal or gamma ablative capsulotomy. These procedures are very invasive. They are not reversible. Once we do the ablation, of course, we can reverse it. The spatial resolution is very good. And this is an effective treatment and FDA-approved treatment. The MR-guided focused ultrasound is actually similar to the other ablation methods, but the focused ultrasound is a non-invasive procedure. Again, this is a non-reversible procedure with a good spatial resolution and is very effective, but don't have an FDA approval yet. Other methods for neuromodulations are the deep brain stimulation, the electrical stimulation, and this is, of course, invasive because we put the electrode within the deep structure of the brain. But this is a reversible procedure, meaning that we don't destroy this area of stimulation. We just put there an electrode. The spatial resolution is very good. This is a very focal stimulation. This is FDA approved for OCD. And we can use new methods for adaptive stimulation. It means that we can use the electrode not only to stimulate the brain, but also to record the activity of the brain and to identify the pathological activity and use the stimulation only to reduce the pathological electrical activity. Other methods are the transcranial magnetic stimulation and the TDCS. These are, of course, non-invasive procedures, and they are reversible, but the spatial resolution is very low, okay? We can only use it for very big cortical areas. The magnetic and electrical superficial stimulation were not proven to be effective in those very severe and treatment-resistant patients, and we don't know if we can use it as method for adaptive stimulation. So if I would think about a future focused ultrasound device, I would like it to be first non-invasive as the MR guided focused ultrasound today, but not to make an ablation, but try to make a neuromodulation of the specific area that I would like to stimulate. And thus the procedure will be reversible. We'll keep the spatial resolution of the current MR guided focused ultrasound. So it will be a focal treatment. And we hope that that's going to be an effective and maybe also adaptive neuromodulation method for psychiatric patients. Okay, so that will be the end of our short talk about focused ultrasound for psychiatric disorder. Thank you for your attention.